And action.
Okay, today we're going to discuss surgical cricothyrotomy, which is New Hampshire Protocol 5.6. It's no longer a prerequisite protocol. They kind of removed needle cric as the preferred option, so surgical it is. So we're talking about positioning at this time and indications. Indications are anybody who's really inadequately oxygenating or ventilating themselves effectively. Contraindications, obviously ability to adequately oxygenate or ventilate, and age. They have to be 8 years or older to perform this procedure. Positioning, we want a hyperextended neck, so if you have a patient on here, you'd like to pad behind the shoulders so that their neck would kind of, their head would flop back, giving you that hyperextension. For the purposes of this demonstration, we're not going to cut into our doll. We are going to use this simulated lung that we have here. We'll discuss our kit. It lives in the side pocket of the advanced airway bag in a Ziploc bag. If the cameraman zooms into our kit here, it unrolls, folds open, a bunch of chlorhexidine wipes, a tube tie, a 10cc syringe, a hook, a scalpel, some gauze, and lastly a shortened 6-0 cuffed tube that comes preloaded with a bougie, and it's shortened just for this procedure. So in this scenario, we'll identify our landmarks, our thyroid cartilage and our cricoid cartilage, thyroid superior, cricoid inferior. We'll determine the membrane between the two by palpating. We want to make sure we're using our dominant hand to do all of this skill. So sitting at the patient's head is the best option. So we'll clean the area, have our gauze available. There really isn't much bleeding involved here. We'll take our scalpel and we first make an incision vertically. We'll go from the thyroid cartilage down through the skin and the fascia in until we hit the cricoid cartilage. We'll hit that rigid area and we'll stop. At this point, we will remove the scalpel. Using our finger, spread the skin and fascia a little bit. We'll then reinsert our scalpel, and now we will go horizontal from side to side. We really shouldn't meet much resistance. Side to side and back the other direction. At this time, we should be able to palpate the opening with our finger. Our finger is the recommended use here, not a hook or spreaders that some commercial kits have made available. So once we're here, we want to introduce our bougie. We should be able to slide it right down our finger into the tracheal space. And in this instance, obviously not as good, but here we're in the trachea. You can see our bougie popping into the lung space. At this point, we'll introduce our tube over the bougie. Keeping in mind, we may have a little bit of difficulty. Some lubricant may be required. But here, in this instance, we've passed the tube. You won't need to go as deep as you would an orotracheal intubation. So we're in, we'll be securing that. We'll have someone inflate the cuff for us. We're in. At this point, we'd ventilate, wanting to make sure that we have end-tidal on the monitor while someone listens to lung sounds and watches for chest rise. If we're in, we should just be able to use tape or our commercial tube tamer to secure the tube in place, obviously leaving some gauze in case there's any capillary bleeding to be had. And that's the protocol.